bear with me a second. I'm just going to try and get okay, I think that's okay. Right. Sorry, I just had a dual screen problem for a second. Can everyone see that screen and hear me okay? Yeah, great. Okay, that's fine. Like with all previous sessions, I'm going to start with the penultimate and the last films that I showed. It's a 25-year-old male who presents with chest pain, and he's got a retrocardiac density, which turned out to be a metastasis from a clavicular osteosarcoma. Message about a film like this is that if I give you a different story, for example, this is a 75-year-old male, this then would be more likely to be a primary, and this would more likely then to be a metastasis. So depending on the patient's age will determine whether or not you're dealing with something more common in the elderly. There are two questions. Is there a tracheal indentation above the carina? No. And is there a deposit in the right seventh rib? Let me have a look. 1, 2, 3, 4, 5, 6, 7. No, it's okay. There are only 2 lesions. Here is the osteosarcoma of the clavicle, and this is the CT demonstrating the osteosarcoma of the clavicle and this metastasis. Note that osteosarcoma mets have a predilection for causing pneumothorax because they tend to grow near the pleura, and so they can then develop a bronchopleural fistula, leading to pneumothorax. Okay, what's going on here? This patient presented with large bowel obstruction. Yeah, so there's a hernia. And tell me the characteristics of the bowel in the hernia. Pneumatosis. Now, it's not actually an inguinal hernia, it's an incisional hernia. So it was a little too high to be an inguinal hernia. But what we've got here is we've got a strangulated hernia. And the strangulated hernia is represented by the pneumatosis that you can see here. Okay, so that's gangrenous bowel within the hernial sac, and that patient was operated very promptly and did very well, actually. That was large bowel within the incisional hernia. Okay, what do you think's going on here? Patient's got headaches. Colloid cyst, yeah, colloid cyst. Colloid cyst, yeah. With hydrocephalus, yeah. Great. So I think everyone who has posted something on the chat is fairly unified in saying that they think this is a colloid cyst. What would happen if you gave contrast, do you think? Nothing. Should we see? What's happened here? Yeah, it's an aneurysm, isn't it? It's an aneurysm of the basilar tip. So this is a basilar tip artery aneurysm. And when I first saw this case, I thought this is going to be a colloid cyst of the third ventricle. But it was just a little bit lower than I was expecting. and I thought we better give this patient contrast. And it was a good job that we did, because it turned out to be a basilar tip artery aneurysm. So there is a differential diagnosis, and unless it's absolutely classical, always subject the patient either to contrast or to MR. So you need to absolutely nail the fact that this is a colloid cyst in the third ventricle or a basilar tip artery aneurysm. Did that catch everyone out? Yeah. Well, I'm glad it does, because it won't ever catch you out in the future or in the exam. Okay. So always make sure you can nail the diagnosis on the characteristic features. The other thing about it is, on the unenhanced study, the attenuation of blood in the entity is not as high as it would be if it was a colloid cyst. Okay, so the attenuation here would be a bit higher if it was a pure colloid cyst. Okay, so that was the other clue. Somebody said, could it be a meningioma? It could be, but I wouldn't expect it to enhance quite so homogeneously. There'd be a little bit of arterial heterogeneity. Okay, and that's the basilar artery here, just getting it in sagittal section here and here. It's out of the frame in the mid portion, but the tip is clearly aneurysmal. Okay, heterogeneity. Okay, and that's the basilar artery here, just getting it in sagittal section here and here. It's out of the frame in the mid portion, but the tip is clearly aneurysmal. Okay, what's going on here? Right paratracheal mass, yeah, excellent. Not a double aortic arch, because, oops, this is going to be much higher than here. Yeah, there's a scapular destructive lesion. So the coracoid process of the scapula and the blade of the scapula have been destroyed. And this was metastatic renal cell cancer. Okay, and this was lymphadenopathy related to that pathology. So on the X-ray, always look around for more than one abnormality. Just have a system for going through the film and make sure you look at the bones as well. And if necessary, make it clear to the examiner that you're using your system to look around the rest of the film. And again, if you ever see destruction of the bone or something that could be attributed to a renal cell cancer, tell the examiner you're looking below the diaphragm to see whether or not there's any surgical clip in the retroperitoneum. Okay, so that's quite important to do that. You sometimes get this in the viva part of the FRCR2B exam. This patient has had a sternotomy. The left heart border is rather straight. There's a dual heart border on the right. There's the right atrium. Here's the left atrium. There's splaying of the carina. There's upper lobe blood diversion. I can't confirm or exclude pleural effusions. There's enough fluid really to confirm that. And you haven't got any of the ossific nodules that you get with chronic mitral valve disease with pulmonary venous hypertension. But this is mitral valve disease. Could this be mitral stenosis, pure mitral stenosis? No, that's the correct answer. It can't be, because mitral stenosis in its own right will not give you cardiomegaly. Okay, so the fact that the heart is enlarged implies that the patient has got mixed mitral valve disease or mitral regurgitation in its own right. Okay, so mitral valve disease, not uncommon in the Viva part of the exam, so recognise this as such and nail it as soon as it comes your way. Okay, this is a young lady, 29 years of age, with weight loss. Anterior mediastinal mass is correct. Posterior mediastinal mass, not so sure. Can you see the aortic knuckle? Yes or no? Can you, before we go into CT, let's see if we can get the diagnosis on the plain film. Okay. You can't see the aortic knuckle. Why can't you see the aortic knuckle? There's a middle mediastinal mass, yeah. So there's a middle mediastinal mass that is obscuring the visibility of the aortic knuckle, okay? And a middle mediastinal mass is anything that is posterior to the anterior tracheal line, okay? And the posterior border of the middle mediastinum is...
okay, I found this.
Sorry, I've got a Siri competing with me. I'll turn it off. So we've got I've lost my train of thought now. Yeah, so anything in the middle mediastinum is bounded between the anterior tracheal wall and a line 1 centimetre behind the anterior longitudinal ligament. Okay. Now, it just so happens that the aortic knuckle is actually in the middle mediastinum. So not seeing it implies that you've got pathology in the middle mediastinum. Okay, so there's a middle mediastinal mass here, but it must be extending anteriorly because it's fading above the clavicle. Okay, so we've got an anterior and a middle mediastinal mass. Can you see the right heart border here? Yes, you can. Can you see the right heart border here? No, you can't. Therefore, this is an anterior mediastinal mass. And the whole point of this film is that once you've got an anterior and a middle mediastinal mass existing in the same patient, you've got a diagnosis of lymphoma. Yeah, very good. So it's almost pathognomonic of lymphoma when you see a mediastinal mass in a young person involving the anterior and middle mediastinum. Okay. "25-year-old male presents with a limp. Any thoughts?" Not hemihypertrophy, not left AVN. There are lots and lots of questions coming in on the chat line. I'd be very happy to answer them if you email me on my email address, which I'll post for you now. Just have a, while I'm doing that, just have another look at that X-ray and tell me what you think is going on. So do send me an email if you want me to answer any specific question. Now, this is very subtle, okay? And if you look at the left femoral head, this has a much lower density than the right femoral head, okay? It's quite subtle, but if you look long enough, you can convince yourself that the density here is much lower than it is here. So, what would be the next investigation? MRI, okay. And what does the MRI show? I don't want the diagnosis, I just want you to tell me what the pathology is that's causing the signal changes. Bone edema, very good. Is it a joint problem or is it a bone problem? Because this is key to the diagnosis. Yeah, it's a bone problem, isn't it? What feature would make it a joint problem? Effusion you can get with joint problems. Acetabular involvement, very good. So if the acetabulum had the same signal as the femoral head, you could confidently say that you're dealing with a joint problem because it's both sides of the joint. The joint effusion that you can see is just a reactive effusion to whatever's going on in the femoral head, okay? So this is bone edema, and it's a bone problem, not a joint problem. What would you tell the patient? Bed rest. Do you know what? I'm not entirely sure about that, but you would offer them lots and lots of reassurance, okay? So pain relief and reassurance. I don't think it's very fashionable to have bed rest for anything anymore. But if somebody would like to look this up and let me know. I think they're just reassured and then given painkillers. But this guy, that was the index X-ray, and 5 months later, without any treatment, the bone density has been restored. Now, don't forget, bone density can be very difficult to appreciate if you've got exposure factor problems. So if the patient's rotated or if there's what we call grid cutoff, you get reduced exposure on one side compared to the other. It can sometimes give you differences in bone density. But this was a real entity. And without any treatment, 5 months later, everything looks okay. Okay, what's going on here? What would this patient look like if you saw them at the end of the bed? Neurofibromas. Now, if it was neurofibromas, would you expect to see some of those outside of the lung in the skin? You probably would, wouldn't you? And the very fact that all of these lesions are only projected over the lung fields, okay, I suppose you could say, is that a rib lesion? But no, it's in the diamond between the ribs. Okay, and somebody has spotted that there's a neck mass here. Okay, can anyone see anything else? There's certainly widening of the superior mediastinum. There's deviation of the trachea to the left. I'll show a different window of the same film. What does that show? What's this? I hope it projects okay. Can I persuade you that this is an esophageal stent? Can you all see that? No, can't see it. Okay, not to worry. Unfortunately, the limitations of technology mean that you can't see it, but there was an esophageal stent here, metallic stent, and this is an esophageal cancer with multiple metastases in the lungs and a metastatic lymph node mass in the neck. Okay, so on my monitor I can see it. Apologies, you can't see it. There's the lymph node mass. Okay, what's going on here? Medullary sponge kidney, yeah. So we've got the calcified ectatic tubules, but without loss of volume of the kidneys. So this is medullary sponge kidney. What's going on here? Diaphyseal achalasia, very good. How is it inherited? Yeah, autosomal dominant, also known as hereditary exostoses. And the concern is that if patients get pain, you're always wondering, is this undergoing malignant change? Okay, so what's the most important thing you can do in a patient with this condition who has pain? Yeah, comparison with previous is the most important, because if it's changed and it's become a bit moth-eaten, you probably are dealing with a malignant transformation. The trouble with doing an MR is it can be quite difficult to interpret. So always go for the easy method first. And then there's a measurement you look for to see whether or not the cartilage cap has grown, and that indicates whether or not you're dealing with a malignant change. I don't know what the measurement of that cartilage cap is, but MRI. And the other feature is that these exostoses point away from the joint. Here's another example in the same patient. That is an exostosis. That's an exostosis. That's an exostosis. There's the lesser trochanter. There's an exostosis here. There's one there. There's one there. There's one there. Okay, what's the diagnosis here? Yeah, progressive massive fibrosis due to sarcoidosis. This is clearly a progressive massive fibrosis that is perihilar in position. Okay, and there is an air bronchogram running through it. It's not the most impressive air bronchogram we've ever seen, but the eggshell calcification coupled with the central PMF makes sarcoidosis much more likely. One thing to note is that there isn't a great deal of silicosis in the UK any longer, because a significant number of these patients have died. However, it may come up in the exam, and you just have to know the difference. And the difference is essentially that the nodules with silicosis tend to be denser. They both cause eggshell calcification. But when you get the progressive massive fibrosis of silicosis, that tends to start peripherally and work its way centrally, okay? Whereas this works its way peripherally from a central position, and that's sarcoid, okay? And like anything else in the chest radiology world, you look at previous films. That is so, so important in establishing which direction the PMF is moving, okay? So always look at previous films. And it's up to the clinicians and the radiologists to make sure that an occupational history has been taken. Okay, what would you see if you looked at that patient from the end of the bed? Right mastectomy, yeah, very good. So they had an old fracture of the clavicle, which is unrelated, and they've had a right mastectomy, and that's all you can see. But in the exam, you would want to tell the examiner that you're looking around for evidence of metastatic disease. Okay, there isn't any in this case, but clearly you would want to do that. And the clavicle malunited fracture was an unrelated pathology. It was trauma a few years earlier. Okay, chest pain. Rib notching, sickle cell disease, third rib fracture, pneumomediastinum. Somebody has sent me a message saying pneumomediastinum. Here it is. There is the pneumomediastinum. There's the parietal pleura stripped off the heart by the pneumomediastinum. Okay. And the important thing is for the radiologist to tell the examiner that you need to exclude esophageal rupture. Okay. So very important to pick this up, very important to think about esophageal rupture. Some of that will come from the history, but there are other causes, of course, asthma, positive pressure ventilation, vomiting, diabetic ketoacidosis. Does anybody know what the difference, the cause of the pneumomediastinum is with diabetic ketoacidosis is? No, okay, that's fine. In ketoacidosis, you get a metabolic acidosis, and the body responds to try and correct that by hyperventilating and giving the patient a respiratory alkalosis in effect. And that respiratory alkalosis normalizes the biochemistry, but in so doing, you get barotrauma to the alveolar spaces. Somebody's asked, how do you differentiate it from the Mack effect? The Mack effect is usually a spurious impression that you've got a lucency because you've got one structure adjacent to another structure with lung in between, and that other structure is usually the lower lobe pulmonary artery. Okay, but this is a very well-defined thin line which has some finite thickness. Okay, with the Mack effect, you just have an interface with a blood vessel that's running that way. Okay, so it's because you've got it, you can see both sides of that thin white line. Okay, trauma. Yeah, second fracture, you all got it very good. There's a fracture at Gerdy's tubercle, and it implies that you've got an ACL rupture, okay? And if you haven't got an ACL rupture, you'll have a fracture of the femoral condyle. Now, which femoral condyle gets fractured if you have a second fracture? Right, lots of people say medial. So the anterior cruciate ligament starts at the anterior part of the tibial spine and goes upwards, backwards and lateral. Okay, so it's actually the lateral femoral condyle. This patient had a lateral femoral condyle fracture, but if in fractures, you're either going to get a ligamentous injury on its own or a fracture on its own, but not both. But usually you get an ACL rupture, but not in this case. Okay, this patient has got multiple cannonball lesions. What's the diagnosis? Yeah, renal cell carcinoma. How can I be so sure? Yeah, surgical clips. The nephrectomy clips on the left-hand side. Okay, and these are cannonball lesions from a renal cell cancer. Okay, so always look below the diaphragm and you might see surgical clips that give the game away. Nephrectomy. Okay, what's going on here? Posterior mediastinal mass, dilated esophagus. Yeah, okay. A dilated esophagus can certainly cause similar appearances. This was actually a gastric polyp. Okay, there's a surgical clip here, it's very subtle, and there's some pleural thickening at the apex. This was a gastric polyp, and they can look very similar to achalasia. Okay, so always look for evidence of previous surgery. The surgeon in this case has disguised very well that they've actually been in the thorax, but sometimes you see disruption of the ribs. Okay, gastric polyp. Okay, this patient has a fall and can't walk. What do you think? Yeah, fractured neck of femur on the left-hand side. Who would go ahead and do a CT? CT, lateral. Okay, I wouldn't have authorised the CT here because I would be fairly sure of the diagnosis. Let me just convince you. Here is the right total hip prosthesis. As a minimum, the radiographer needs to just include the lower stem and get a bit more of this in view. So there's an argument to do another X-ray to cover the entire prosthesis, okay? So that needs to be done. But actually, we've got this density here as the trabeculae from the femoral head are overlapping the trabeculae from the femoral neck at this point here. And we've got a discontinuity of Shenton's line, okay? And there's a hint that there might be a fracture there. Anyway, this patient did get a CT, and the CT just shows you what you can see on the plain film, which is the density as the trabeculae overlap, and the disruption in Shenton's line, and the fracture just here. Okay, so you don't always need to do a CT to get the diagnosis if you're confident about doing plain films. Now, somebody said we are not as good radiologists as the previous generation, and that is a private message. Now, I don't agree with that. I think you are different radiologists. So you are exposed to more cross-sectional imaging, whereas I'm old enough to have done lots and lots of plain films. But if you become really good at looking at plain films, you'll find cross-sectional imaging relatively straightforward. So I think that's an important thing. And because the younger generation are focused on cross-sectional imaging, that's exactly why the college tests you on plain films. So do try to be good at plain films, and I think you'll find the rest of your radiological skills will become enhanced. So it's quite an important point. There you go. So impacted fracture. I may have shown you this several times before, but a bit of repetition does no harm. And for those people who've tuned in for the very first time, it's a cracking case of hemochromatosis. Hook-like osteophytes, second and third MCP joints. There you go. And we've got TFC calcification there and there. Hemochromatosis leading to CPPD, and the crystal in CPPD is calcium pyrophosphate dihydrate deposition. Okay, this is a CT cystogram in a female who has been involved in a road traffic accident. So there's a fracture of the superior pubic ramus on the right, a fracture of the superior pubic ramus on the left in 2 places. There's a fracture of the sacrum. There's a little diastasis of that SI joint. Okay, but what is the CT cystogram showing? Yeah, there's intraperitoneal bladder rupture, and somebody has correctly spotted that there is also extraperitoneal bladder rupture. Okay, so here is the intraperitoneal bladder rupture. So we've got the contrast interspersed between loops of small bowel, so it's in the peritoneal cavity. Here's the uterus, there's the broad ligament, very nicely demonstrated. Here's the bladder, and just outside the bladder, in the extraperitoneal perivesical space, we've got contrast. So it's likely that the fractures have been responsible for the extraperitoneal rupture, and blunt trauma to a distended bladder are probably responsible for the intraperitoneal component. And so what does the radiologist need to do as an urgent action? Any thoughts? Yeah, call the surgeons, and they need to repair the bladder rupture pretty quickly, because there is a real risk that the urine in the peritoneal cavity can cause a peritonitis, and it's a chemical peritonitis. Okay, now clearly if the patient has got a urinary tract infection, they might get a bacterial peritonitis as well, but it's really the chemical peritonitis. Urine is very irritant to the peritoneum. So pick up the phone the urologists. They're not so concerned about the extraperitoneal bladder rupture, but they are concerned about the intraperitoneal bladder rupture, and they'll do it the same night, hopefully. Okay, this is a super scan in a patient who has an above knee amputation. You can't see the kidneys, but you can see lots of homogeneous bone uptake and quite a lot of bone uptake in the skull vault. Yeah, any thoughts? Yeah, this is actually hyperparathyroidism. So one of the causes of superscan is prostate cancer or breast cancer. But don't forget, metabolic conditions such as Paget's and hyperparathyroidism can cause the same type of superscan. Although, in my experience, if it involves the skull and it looks fairly homogeneous elsewhere, it tends to be the metabolic causes. Okay, whereas the metastatic causes tends to be very heterogeneous. Now, I was once co-examining on the Aintree FRCR course, and my co-examiner showed a bone scan of a patient who had no uptake above the right knee and, above the left knee and below the right knee. Okay. And the rest of the bone scan was okay, and they presented with what was thought to be bone pain. So in this particular case, why has the patient had an amputation? I've no idea, but it's not relevant to the case. But in the case I've just mentioned, where my fellow examiner showed this case, and you could see there was cut off above the knee and below the knee. It was because the patient had acutely ischemic legs. If you block off your arterial supply, you don't get the MDP agent to the bones that are distal to that arterial blockage. So that's another potential cause of an unusual bone scan. Okay, but this was actually an amputation. Right. Okay, this is a potentially tricky one. Sagittal reconstruction of a neck injury. C2, 3, 4, 5. C5 is 50% more anterior than C6. Okay, so I'm thinking bilateral facet dislocation. When you do the axial image, we've got a naked facet here and a naked facet here. And the parasagittal image shows, yeah, the facet is no longer articulating with the facet below. So that's on the right side. And on the left side, it's exactly the same. So we've got a bifacetal dislocation, okay? And if I go down to the right side, it's just fallen off its perch, okay? So perching is where the posterior facet of C5 is just still articulating with the anterior facet of C6, but this has completely gone over, and we've got a bilateral facet dislocation. And you can only imagine what sort of problem is going on with the spinal cord, having to negotiate that very narrow space. these patients always get cord damage. Okay, this patient presents with hemoptysis. Any thoughts? Right mid-zone mass. How big does something have to be a mass? Yeah, 3 centimeters. So I would describe this as a 2 centimeter nodule projected over the right mid-zone. Why do I use the word projected? I'm actually going to type this out for you. Yeah, so if you use that phrase in the exam, the examiner cannot fault you for that because it is a nodule that is projected over the right midzone. Okay. Now, could it be in the bone? Well, yes, it could, except I can just see some of it, a crescent of this lesion projected outside the bone. So that tells me it could either be in the lung. It's probably not going to be in the pleura because I can see all the way around it. Okay, and if it was in the pleura, I would have an incomplete border sign. Okay, so what would you do next? Patient's got hemoptysis. Yeah, do a CT. Okay, I agree with that. I'll just show you the close-up just to show you that the lesion goes all the way around here. But we did a CT scan. Any thoughts? Could be skin, yeah. Button, yeah. Where is it on this? We're just at the level of the arch, but we can't see the nodule. And as I scrolled up and down, I couldn't see the nodule. Notice that the patient's got central lobular emphysema. So where is the nodule? On CT, there's a posteriorly seen flat structure, yeah. Okay, so what would you do next? Examine the patient, yeah, very good. Yeah, examine the patient. Always examine the patient. But in this case, we did a prone, and there it is. So it's a skin lesion on the patient's back. What a great case, yeah? And it just serves to illustrate that when you describe a chest x-ray with a solitary lesion, why don't you describe it as a lesion projected over the midzone, yeah? So that you leave yourself a bit of wiggle room to say, yes, it's a skin lesion or it's a lung lesion later on, okay? If you have lots and lots of lesions and they're only projected over the lungs, it makes it more likely that they are lung lesions, okay? Now, somebody's asked, what about a lateral view? I think in the UK and in my practice, the very mention of the word hemoptysis would encourage me to do a CT scan in this situation. Okay. Now, if you have the luxury of examining the patient and knowing that they've got a skin nodule, well, yeah, that's fine. But they would probably warrant some further investigations just on the clinical history. Okay. So skin lesion. So always describe things as being projected over the lung fields, because you can never be wrong. But if you say it's in the lung, you might have to backtrack and do a U-turn. Okay. Now, you probably have never heard of this condition. It's extremely rare, but it's a great demonstration of central lobular nodules. Central lobular nodules are equally spaced from each other because they represent the centre of a secondary pulmonary lobule, which by and large have the same dimensions as the one next to them. So the centre of this geometrical structure is likely to be equidistant from the next centre and the next centre and the next centre. So central lobular nodules tend to be very well ordered like this, okay? And as they become more pronounced, they start merging to produce this ground glass change. And one of the characteristic features of central lobular nodules is that they give this peripheral spurring, because of course they are in the centre of the lobule, not in the periphery of the nodule, okay? And it just so happens that thoracic lymphangiectasis is a condition where you've got communication between the bronchus and the thoracic duct. So all the chylous fluid goes up the thoracic duct. About 90% of it goes into the subclavian vein on the left-hand side, but a significant proportion of it goes into the bronchial tree because you've got this communication, and it produces central lobular nodules. So it's just a really nice demonstration of that. And I've only ever seen this case once. What do you think happens when this patient was asked to cough into a jar of cold water? Anyone, any thoughts? Yeah, it produces a cast. Do you want to see it? That is a cast of the patient's bronchial tree. So a very quick-thinking respiratory registrar, when we'd worked out what the diagnosis was, asked the patient to cough up this cheesy sputum into a jar of cold water. Now, at room temperature, fat solidifies, and at body temperature, it becomes a liquid. And I think that explains what you're seeing. Now, you'll never ever get shown a case of this, but it just shows you the central lobular nodules. I think it's just a really nice demonstration of central lobular nodules. Now, I hope that didn't put anyone off their dinner, okay? And I hope you found this useful. It's 7:25, and it's an appropriate time for me to say that my supper is ready, and I'm going to play Supper's Ready by Genesis. Until next time, see you on Monday. Sitting beside you, I look into